I think we used 22 or something. So we used about 11 cc's of sodium tetradecyl sulfate liquid made up to foam. Maybe we could have used a little bit less in him, but we thought we needed to get something treated, and what is said is that the more swelling you get, the better is the end result. It's difficult for all the patients initially when they have a lot of swelling. They don't like it a lot, and you can understand that. For him, we thought we would just, get this degree of swelling, and he's managed very well. He's eating and drinking. The following day he sat up watching TV with a video control, drinking through a straw.
Another agent that is commonly used is polidocanol.
Yes.
But that did not feature in the list of the eligible
and that's not
agents.
And that's not because I'm biased, it's just that I've not used it. Where I've worked and where I work now, we've not used polidocanol at all, but I know some people do use it and say it's very good.
Okay, we have been using that.
I know for vascular surgeons, they're keen favourites of polidocanol as well. The reason we used sodium tetradecyl sulfate was I used to use alcohol, and I switched to using sodium tetradecyl sulfate for venous malformations. And foaming it is really easy, and it seems to be fairly effective. The results are actually, but some people suggest that the achievement of a result, for example, if you're treating for pain, say, is quicker if you treat with alcohol than if you treat with sodium tetradecyl. So you'll need less number of sessions. But I don't know the answer, to be honest.
I have used both sotalol and polidocanol. Effectively, there is no difference.
Yes.
You can see at the end of the procedure, it looks very tense, and as expected, the mucosa had blistered the next morning. But since the patient was already prepared for it, and he also told them that if it ulcerates, he put Neosporin ointment for 5 days and it will settle down. We've asked this patient to come back and see us after 6 weeks, when we'll be repeating the cycle one more time. By the way, one of the problems that happens when you mix air into tetradecyl sulfate is, though it forms, it breaks very rapidly and separates. So one of the tricks that he told us was to add Lipiodol into it. So into a mixture, say about 8 cc plus 8 cc, that's 4 ampules, you can add about 1 to 2 cc of Lipiodol, and then you find that the foam continues to stay for a longer time during this injection. After the procedure was done, the patient had mild hemoglobinuria, and the recovery room people were pretty worked up seeing so much of reddish colored urine, but just like we predicted, it lasted for a few hours and cleared completely. Did not have much pain, but the whole area obviously is very edematous. So the thing is, what do you give him to eat? So he had liquids for straw. He was encouraged to take ice popsicles, which would be convenient for him, and the next stage he could start taking semi-solids.
So we give him, we'd make sure that he was well hydrated afterwards, and all patients with venous malformation sclerotherapy would get twice normal volume of maintenance intravenous fluids for 4 hours. If we're doing a significant sclerotherapy, and I would consider 22 cc's of foam as being significant, we actually put a Foley catheter in as well when they're asleep under GA, and the Foley catheter stays in for 4 hours. And if their urine output, that volume of urine is normal per hour for 4 hours, and if it's normal in colour, then the Foley catheter is removed. Many patients at that point, depending on the location and the degree of swelling and pain, but most don't get pain significantly at all, can be discharged home. It depends on the circumstances. But urine is really important to monitor, and the Foley can be taken out at 4 hours. Not every patient do we put a Foley catheter in, but if we're putting a significant amount of sclerosing foam in, we put a Foley in, because particularly in the babies and the toddlers, trying to measure the urine output is not always easy at all, and it gives you much less of a headache, I can tell you, and then the catheter can come out.
Just once again, getting you to understand the picture of how the injection is made, the tubing is full of contrast, and then you go on road time. So now we know when the contrast column is pushed forward, and you get unopacified foam coming, the tubing looks white. So now you know that the contrast has gone forward, and now it's just foam. Then what you see is the leading edge of contrast. So as you see the leading edge of contrast, you will go into the malformation, and a point of time you will
can I just, can,
You got it?
After exiting of percutaneous injection, any plan for surgical?
No, that's what he said. He may take not next, he may take 5, 6 sittings before it shrinks to a point, and when you don't see the significant venous leaks, and that's the time you send him for surgical reconstruction.
Surgical reconstruction, whether it will enter the wound healing during the after
No, they're not touching the arteries. If it is an arterial, what's venous? We're not reduced ischemia. Actually, healing will be better because the compartment pressure is so less.
Any antibiotic coverage has to be?
no, not usually for venous malformations. If they develop ulceration, then that can actually take months to heal, and for just 5 days or so, we normally just give them. We actually use polysporin in Canada, put some neomycin ointment for a few days is adequate, and then we'd actually regularly put some Vaseline on it and make sure it stayed moist. One thing I didn't mention maybe was about the volume of sclerosant, the total volume, and we did mention about some people say 10 cc's of liquid sodium tetradecyl sulfate. So that means 20 cc's of foam without the Lipiodol. So if you added 2 cc's of Lipiodol, maybe 22 cc's. You can go further, but you have to be very cautious. I would never suggest going further once you first start doing these at all. You can run into problems. So that doesn't mean that if you've got a venous malformation of the finger, you're going to put 22 cc's of foam in. Okay? You might only put 2 cc's at the most into a finger. You would be worried about significant swelling and the arterial inflow into the finger if you were to put too much. So be very, very careful with the dose. So the dose depends on the weight of the patient, the dose depends on the lesion that you're treating, and the location of the lesion, where it is as well, and also your experience. Ideally it should. So I work in a hospital where our equipment has gone old a little bit. And one of the ideas of adding Lipiodol is to use it as a positive contrast, so you can see it when you're injecting the foam. And sometimes we find Lipiodol not easy to see in one of our interventional rooms. But many radiologists doing these now don't add the Lipiodol for opacification. They add the Lipiodol to stabilize the detergent foam. You should have a good idea from the director. So what you do when you inject the contrast, you do a DSA. When you inject the foam, you actually do a Is
there any role for a similar treatment in non-epileptic conditions?
Well, because they're tumours, all you would be doing is causing sort of
Pre-op.
sorry, no, not for direct sclerotherapy. If you were to trying to preoperatively reduce the hypervascularity in a niche, then it would be an arterial study and an arterial embolization, not a direct puncture.
Prior to surgery, then revascular surgery. And then also you must encourage whoever doing slightly under-embolization, so their healing can become a problem. So sometimes people feel that they must make it so bloodless that you will say I had a fantastic bloodless surgery, then the wound won't heal. So you under-embolize, tell them to go as close to the lesion as possible, and it's particle embolization. Any points anyone wants to share? You got the dose of the steroid, one single dose of steroid, and in this case we use one shot of 8 milligrams of.
I don't think he got 8 milligrams because he wasn't. I think he might. I can't remember how his body weight, but he got 0.1 per kg rounded. So he would have got 4 milligrams. He would have got 4 milligrams of dexamethasone. We rounded up to the nearest thing.